Okay, thank you. Good morning. We heard a lot in this meeting about amyotrophic lateral sclerosis, so I'm gonna skip this part of the introduction. We also heard about the mouse model. Here you use transgenic mouse that expresses multiple copies of the mutated superoxide dismutase 1 gene, which is a dominant mutation. And this animal model also develops most of the symptoms of the ALS patients. So in order to set up a gene therapy strategy for amyotrophic lateral sclerosis, we choose the adeno-associated vectors that have been demonstrated to be efficient and safe in preclinical and also in gene therapy clinical trials. Also, the different serotypes of AAV vectors give us the possibility of differentially select the target tissues, for example, muscle and CNS in this disease. And we also can combine the different serotypes of vectors with a specific route of administration. Thus, for example, by intrathecal delivery of the virus into the CSF. I'm sorry, my screen is not working. Well, I can watch it here. So by intrathecal administration of the virus into the CSF, we can target the central nervous system. While if we want to target the liver, we can directly inject the virus in, if we can target the muscle, we can specifically inject the virus into the muscle, but this is not translatable for an ALS patient. So we can deliver the virus also through circulation and reach most of the tissues in the body, but most of the virus will go into the liver. So in order to specifically inject or infect a specific organ, we can use a specific promoter. For example, here, a muscle promoter. So as a proof of principle, we use the human desmin promoter, driving the expression of a reporter gene, the luciferase, and we injected two different serotypes of vectors into wild-type and SOD1 animals at two different ages. At 10 weeks, when the animals start to develop the first symptoms of the disease, and at 15 weeks, when the animals already have a very well-established ALS phenotype. Here is the in vivo distribution of luciferase, and independently of the genotype of the animals or the time at which we have injected them, we see quite good distribution through different muscles in the animals. Also, both vectors behave in the same pattern. More specifically, you can see here the ex vivo activity, and on the right part of the slice this slide, you can see luciferase activity in the different muscles: gastrocnemius, quadriceps, soleus, and tibialis anterior. And you see here that we have very high levels of activity in these muscles compared to liver and lung, for example, where we only have background levels. So this promoter is specific and efficient, infecting the muscle, and the animals that already have manifest symptoms of the disease can be efficiently infected also with a vector. So in order to find gene therapy strategy that could target as many patients as possible, we decided to use neurotrophic factors. And we already have shown that neuregulin-1 promotes functional improvement in this model. And you can see more details of this work in poster number 20 in this meeting. But here I'm going to explain you our results using glial-derived neurotrophic factor. It had been already shown that GDNF can protect dopamine and motor neurons in different animal models. In particular, in the SOD1 animal, when it's injected into the spinal cord, it can protect motor neurons, but not the neuromuscular junctions, which are really affected in this disease. On the contrary, by administering GDNF into the muscle, for example, in a transgenic model that express GDNF in the muscle specifically from birth, and crossing this animal model with an ALS model, it was demonstrated that can protect both motor neurons and also neuromuscular junctions. However, when GDNF was injected systemically, only modest functional results were obtained, but adverse side effects like loss of weight and memory deficits were shown. So we wonder if we could efficiently and specifically deliver GDNF in most of the muscles in this animal model. So we set up a preventive gene therapy strategy with the SOD1 animals using AV8 that was intravenously delivered in these groups, and also a null vector as a control. And we injected the animals at 5 weeks of age, and we followed them for 3 months. So we could demonstrate an increased expression of GDNF in different muscles. Here, gastrocnemius, tibialis, similarly as we have seen with luciferase, at both mRNA and protein levels. And more importantly, we also saw an increase in the expression of RET, which is a core receptor for the GDNF. And consistently with this increased expression of the receptor, we also see an increase in phosphorylation of AKT and ERK, which indicates that we have activated survival signaling pathways in this muscle. The neuromuscular function was evaluated by electrophysiology, and you can see the red lines that correspond to the animals that were treated with GDNF, and compared to the black line, we do see a preservation of the motor neuromuscular function in these animals, in both sexes, and we also see a better performance in the rotar rod, indicating a delay in the disease onset. We analyzed histologically the neuromuscular junctions. And if you can see here in green, the motor end plates in the non-treated animal, there is lack of innervation since the motor axons are in red. And when we quantify this, we see that there is also preservation on the neuromuscular junction. We also analyzed the spinal cord of these animals, and we didn't see increase of GDNF as expected, because we only target the muscle, but we did see an increase in the core receptor, which is consistent also with the increase in the activation of the survival pathways. Neuroinflammation is another hallmark of this disease. And as you can see in this slide, the number of astrocytes in the GDNF-treated animal, as well as the number of microglia, are also decreased in this model. And finally, the motor neurons were quantified in the ventral horn of the spinal cord. And as you can see, the GDNF-treated animals preserve the survival or increase the survival of these motor neurons compared to the non-treated animals. So here I have shown you that by intravenous administration of this vector targeting the muscle, we could increase or activate the survival pathways both in the muscle and in the motor neurons, and protect the neuromuscular junctions as well as the motor neuron survival. And this is the people working in this study, Belen, Guillem, Mireille, and Sergi, and also the funding agencies for this project. And the vectors were produced at the viral vector production unit at the UAB. Thank you.
It's time for a very quick question. Anybody? If not, I do have one. I just remember a very similar model a couple of years ago, just showing kind of a different results with, well, actually, didn't show an increase in survival, and apparently there were some cognitive problems using a different virus. That's the only big difference that I can remember.
In previous published work, they just injected the vector into the muscle or into several muscles, but not in the, they couldn't target the whole or most of the muscles in the body. While when it injected into the circulation, it mainly goes to the liver, and because it's secreted, the liver is a good secretory tissue, so it goes through the whole body. And then they have adverse events. They decrease activity, decrease weight, so it has secondary effect. So the advantage here is that we can distribute the vector through all the skeletal muscles, and from there, protect the neuromuscular junctions and the motor neurons.
Thanks.